So I'm Dr. Sarita Rao. I'm an addiction psychiatrist, and I actually used to be on the board of the Root Center, but and I love the Root Center and all the work that you guys do, but because I'm so overcommitted, at one point I did have to step off the board. And I'm an associate professor of psychiatry at the at UConn Health at University of Connecticut School of Medicine. And co-presenting with me today is Dr. Catherine Wright, Dr. Cat Wright. She is a third-year psychiatry resident, which means she has finished medical school, 3 years of psychiatry residency training, and is actually going to become our outpatient chief resident next year. So Dr. Wright's been doing addiction psychiatry clinic with me every Thursday afternoon, and so has developed a very good knowledge base about substance use disorders. So our topic today is mothers and substance use disorders. We're also going to discuss, pregnancy and breastfeeding as part of this. We will try to utilize the words pregnant persons to acknowledge that it's not only cisgendered women who could be mothers and or parents and have pregnancies, but the scope of our presentation today is predominantly on cisgendered women of all different races. Just wanted to clarify that. This is the American Society of Addiction Medicine's definition of addiction. It's a really good definition. I usually start my presentations with this, even for an audience that is very knowledgeable about substance use disorders, like everyone here today. So it's a good reminder for all of us. Addiction is a treatable chronic medical illness involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. So that's kind of a key diagnostic factor for diagnosing whether somebody has a substance use disorder or addictive illness is use despite consequences. And the fact that we're saying it's a treatable chronic medical disease, it's one of the most hardwired brain diseases there is. But because so much of the behaviors are result in social outcomes, people, even within the healthcare field, still have a lot of stigma and think of it as more of a social or behavioral disease. But it's really even more hardwired in the brain than maybe schizophrenia. But often our patients get like less sympathy for their condition. There is, of course, an element of choice, but it's not an easy thing. Like, am I going to eat this donut or not going to eat this donut? And sorry, Dr. Wright, the previous slide. So prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. This is a big thing for stigma, because if somebody with high blood pressure comes back and they've had a heart attack or a stroke, if they've been eating, if they're somewhat overweight, like, people might counsel them on it, but they're not going to really blame them for it. They still get a lot of support. They're not expected to go to the ICU once and then never return. Well, that would be the ideal outcome. So the next section is a little bit about neurobiology of addictions. It's a good refresher for all of us, and it might contain also some new learning for some people. So the thing to remember as we go through this presentation is that the brain does not know the difference between a legal drug like alcohol, nicotine, now marijuana in Connecticut, an illegal drug, a prescribed drug, or a drug bought on the quote-unquote street. So to the brain, it's all the same. If it's potentially addictive and there is a genetic vulnerability to addiction, then the brain will latch on to something. And then another thing that's important that I sometimes say to patients when they say, Dr. Rao, can I have something else that's going to work just as well as this benzodiazepine? I tell them there's nothing in science or nature that can recreate the effects of addictive substances on the brain. If there was, then people would be easily treated by putting them on something else. There's some kind of background noise from the next office. Are people hearing it at all? No. Okay, that's good. So this is a little bit of an sort of 3,000-foot overview of the neuroscience. So the mesolimbic pathway, when we say pathway, we mean a set of nerve cells in the brain, like a bundle of nerve cells that all kind of run together and usually are making the same neurotransmitter. And neurotransmitters are these proteins that our brains make, and they are a way for one cell to speak to the next cell and send messages. And it's a pretty complex process. So the mesolimbic pathway is one of 3 dopaminergic pathways in the brain, which means that the predominant neurotransmitter for these pathways is dopamine. And dopamine is the reward and reinforcement neurotransmitter of the brain. So this mesolimbic pathway is the one most implicated in any kind of addictive illness. It is very phylogenetically ancient, meaning as we evolved from simpler animals like reptiles, into the mammalian species that we are, that along the way, this pathway came with us. So it's designed to mediate drive behaviors like food and sex, because if the animal or the organism didn't eat, it would die. And if it didn't mate and have baby animals, then the species would die out or its genes wouldn't go forward. So the mesolimbic pathway is designed by Mother Nature for keeping us alive and, making sure there's some new baby animals to take our place, and to make sure that, any species keeps their young alive. But it's a very hardwired pathway because it is so evolutionary. From an evolutionary perspective, it is so old that it can sometimes be thought of as the lizard brain, which is a slightly controversial, term now. So you may or may not want to use it. So by lizard brain, I don't mean anything speciesist about lizards, but they have a much simpler brain than, let's say, human beings. But they also have this pathway, which is very similar in their brain as well. And in the addictive illness, the reward and reinforcement pathway of the brain is hijacked, for lack of a better word, and to make the brain think that the drug is more important than survival and survival of the next generation. And when I say drug, I also include alcohol, because alcohol is a drug, right? We say alcohol and drugs, but alcohol is a drug. If it was invented today, it would be a controlled substance. So that's, Kat, you could advance the slide. Thank you.
Okay, and then I am doing the next section, Dr. Rao. So we're going to talk about gender and sex differences in substance use disorders. And a lot of this information is coming from an article in the Journal of Neuroscience Research, which is really an excellent article if you have time to read it. But the basic idea is that we do see differences in addiction and in the behaviors based on not just biological sex, but also gender. And the idea is this complicated interplay between biology and then also social constructs, and that it is shaped by those sociocultural structures and processes over time. There's been a lot of basic science research in rats and monkeys, and we'll touch a little bit on that in the next slide. But we do see that it has demonstrated that addictions and consequences of addiction differ by biological sex and also by gender. So talking about some of those studies. So there were studies that were done both on monkeys and rats, and they exhibited some similar sex differences in addiction-like behavior. And those are different for the male rats and monkeys versus the female rats and monkeys. And it really showed that one of the examples was that women, the female rats and monkeys, tended to start showing the compulsory behavior earlier, and that so it's kind of an important thing we also see in humans. And then the effects of the environment and positive or negative effects can also influence the brain, and that impacts the vulnerability to addiction differently in male and females. All right, and then this is you, Dr. Rao.
I had muted myself.
You are muted.
So now we're going to talk a little bit about stigma and labeling. So stigma and labeling actually ties into the previous two sections. So it ties a little bit into neurobiology because people don't want to see substance use disorders as hardwired brain diseases, even within healthcare. And also sometimes, the gender differences are biological and sometimes they're social or a mix of the two, which results in women having greater stigma and labeling. So stigma is greater for women with substance use disorders or any kind of addiction, whether it's gambling, a process addiction, sexual compulsivity, whatever it might be. And when I say exchanging sex for drugs is common, I should probably change the sentence. Exchanging sex for drugs is common if the woman who suffers from a substance use disorder is also sort of socioeconomically has reached a socioeconomically depressed point where either it's due to the substance use disorder or to begin with didn't have much money, and now at this point they're sort of desperate to relieve withdrawal or get the next euphoria. And so I mean, unlike a man, they're not going to be as effective physically at mugging somebody, or they're less likely to like break into a store or something, although they do that as well. And so they will sometimes, out of desperation, exchange sex for drugs because physically it's kind of more feasible for them to do that than to like mug somebody and take their money or do an armed robbery or something. But this results in a lot of trauma for them and also stigma. And, I'm sure all the therapists and nurses and doctors in the room are aware of this, is that, if they share about these experiences in mixed therapy groups or mixed NAAA meetings, sometimes the men will perceive them differently and treat them differently outside of the meeting. And I've heard this many times from patients. So that is a really bad feeling for them. So this is why we sometimes send them to women-only 12-step meetings or women-only therapy groups. And in general, even though so much progress has been made in terms of equality for women and for mothers, I mean, whether you have a substance use disorder or not, there's still so much like things ascribed to mothers, like if our children don't do well, then its mother must have done something or not done something. So society's view of a mother or a quote unquote good mother is not compatible with a person who has an addictive illness. And a lot of times, people will think of these mothers as being quote unquote bad mothers, which is an unfortunate label. And so all the stigma and labeling is a barrier, and this prevents women, especially mothers, from sharing about their addiction and trying to get treatment for it. They're afraid of DCF. They're afraid that their children will be taken away by by the dads. They're afraid of a variety of things. And this is a little bit about some of the challenges that women with substance use disorders face in relationships. Sometimes it makes them more vulnerable to stay in abusive relationships or somehow get entangled in abusive relationships, which could be physical, emotional, sexual, verbal. There are a lot of women who have been first introduced to whatever their drug is by a boyfriend or a husband, and then the relationship ends and they are kind of left with a substance use disorder, but the relationship is over. Sometimes they might, exchange sex for drugs in order to get money for or get drugs for themselves and their partner, but then the partner also kind of looks down on them and resents them for it and, might be verbally or physically abusive. There are a lot of codependent relationships. We talked about the exchanging sex for drugs. Then there can also be quote unquote mutual abuse because there's a lot of conflict in the relationships brought in by the fact that one or both people are using addictive substances. And this could be in every level of society. You could be living in a mansion in some expensive, part of Connecticut and be fighting behind closed doors, drinking, using drugs, whatever. And then another big thing is a lot of times if their mother and the children's father does not have a substance use disorder, then they will fight them for custody in court and they will take away the kids out of their own anxiety and they will this results in a tremendous loss for the mother as well as for the children. And one thing to always remember is that mothers with substance use disorders love their children the same as any other mother, but they may not be able to get clean and sober in a timely manner to look after them and keep custody. They might not be able to get into any kind of treatment in a timely manner to get custody. That does not mean that they don't love their children. It's due to a brain phenomenon called salience. And I deliberately didn't put that into the earlier slides. So when you think about the hijacked brain, which is the mesolimbic pathway and the VTA, the ventral tegmental area of the brain, then salience is something where, let's say there's a mother who is using, cocaine, and her baby is crying at night. Like, we are all wired as mammalian, mothers to kind of, even if we're exhausted, tired, whatever, hungry, we're going to feed the children, or we're going to, prioritize their needs first. It's not just humans. But so the mother hears the cry, but her brain doesn't give it salience, which means the brain pushes it back. She can hear it, but the brain gives importance to the drug because the mesolimbic pathway has been hijacked. So it's not a simple choice that they're hearing the child cry and they're not getting up and they're still using the cocaine. It's an issue of salience. Sometimes if you're multitasking and somebody comes into the room and they tell you something important, but you're also typing an email, you hear them, but you don't really register it in quite the same way, and you don't react because your brain's not giving it salience. That's the easiest example I can think of.
Okay, and then I'm covering this next section. So now we're talking about alcohol use disorder, starting off with just general differences in women and men. So generally, women tend to have alcohol-related problems at lower drinking levels than men. There's a few reasons for this. One is a telescoping phenomenon. That really goes back to the gender and sex differences. And as far as that, women tend to start to have that as a compulsive behavior earlier, and then tend to stabilize at higher effects. But there's also just a difference as far as body composition. So because a typical woman weighs less than a man, they obviously, the same amount of alcohol is going to have a bigger effect. But also the fat and water composition. Women have a higher percentage of fat versus water, and so our volume of distribution is less for the amount of alcohol that's being consumed. And there's a few important health risks that are more common in women than men. One of them is liver damage, in particular liver inflammation, which most likely goes back to the the kind of reasons we talked about why it tends to be higher risk. And then also breast cancer. Individuals who drink one drink a day are more likely to develop breast cancer than their peers who do not drink. And then moving on to alcohol use disorder during pregnancy, talking about fetal alcohol spectrum disorders. And I think now in the US, this is, I think, well known that this is a risk. And we're really going to talk about a spectrum of disorders. There's quite a few different ones. Fetal alcohol syndrome is the one that's the most widely known, with its different facial components and all of the elements of that. There's also partial fetal alcohol syndrome, alcohol-related neurodevelopmental disorder, and then just a general term of alcohol-related birth defects. And people with fetal alcohol spectrum disorders, besides just the physical effects that they have, such as impacts in coordination, they also have a variety of behavioral and cognitive effects. So a lot of these people have trouble with them as they grow up. So the babies that were exposed in utero have difficulty with emotional control. And so that can really factor into their success when they're younger in school. Between the emotional control and the cognitive effects, that can have a real impact on them with their peers and in their education, which is really going to follow them into when they're in a job. And then they're also more likely to sort of make bad decisions or be victimized by others. And then, so that can really lead to a lot of problems over time. As far as the risks of fetal alcohol syndrome, it's going to be based on when in development the mother is drinking and how much they are drinking. And anything that would normally impact a sort of fetal development is going to also play a role. So is the pregnant person, are they getting prenatal care? What is their nutrition status and their health status at baseline? And then what are they, kind of what's their support structure? What kind of stress do they have around them? And then also, what is their culture like as far as acceptance of binge drinking and awareness of fetal alcohol syndrome? Okay. This is still me, Dr. Rao. So now moving into some more, kind of just general, kind of going into different substances during pregnancy. This is pulled from 2013 from the National Institute of Drug Abuse. It was the most recent stats I could find, but it's about stillbirth. And one of the highest risks of stillbirth is actually with nicotine use. So with tobacco in particular, there's a 1.8 to 2.8 times greater risk of stillbirth. And the higher amount is, based on how much they are smoking. It's even a risk with passive exposure to tobacco, about 2.1 times greater risk of stillbirth. Some other important ones are marijuana use. That's 2.3 times greater risk of stillbirth. And then in general, any stimulant, prescription pain reliever use, 2.2 greater risk of stillbirth. And going in a little bit more about marijuana use during pregnancy, the evidence is, we haven't really done a lot of research on this. So there's not a lot you can find. We do have that statistic about the risk of stillbirth. There isn't human research about the risk of miscarriage. That makes it a little difficult. But ACOG, which is the American College of Obstetricians and Gynecologists, does recommend that pregnant persons should not use any sort of cannabis product while trying to get pregnant, during pregnancy, or while they are breastfeeding. I think it's something, now that it's legal in a lot of states, something we kind of need to be thinking about because there just isn't a lot of research. And there's a lot of environmental factors that also play into this as well. And it's hard to tell the effects of just cannabis versus the other environmental factors at play, things like nutrition, prenatal care, all those kind of important things. One thing we do know is that prenatal marijuana exposure is associated with an increased likelihood of that person using marijuana as a young adult, even when we do factor in, the other elements that could influence drug use. And then cocaine use during pregnancy. So prenatal exposure of cocaine, those babies are more likely to be born with low birth weight and have smaller head circumferences as well as length. And then at birth, there is a syndrome that we tend to see that is a irritability, hyperactivity, tremors, high-pitched cry, and excessive sucking. It's a little unclear if this is due to more of an acute intoxication from the cocaine or if this is a withdrawal effect, because the cocaine metabolites can still be found up to 7 days after delivery. And we do know that during pregnancy, there are a lot of risks for the mother if they are taking in cocaine. So they are at a higher risk of maternal migraines as well as seizures, premature membrane rupture, so that would lead to, which can lead to early delivery and a whole bunch of different complications, and then placental abruption. And that is where the placenta comes loose from the uterus, and that's before delivery, before anything like that. So it's a medical emergency, very dangerous. And then during the pregnancy as well, cocaine is going to have the same effects on, somebody who's pregnant cardiovascular wise as it would on anybody. So increasing the heart rate, increasing the blood pressure, and high blood pressure in pregnancy can be very dangerous. It's why we monitor for that. So that can have effects as far as spontaneous miscarriage, premature birth, and then also difficult delivery. Okay, and then this is you, Dr. Rao.
So now I'm going to talk a little bit about opioid use disorder during pregnancy. Just a reminder to everyone that both cocaine and nicotine are reduce blood flow to different parts of the body. And so that is a big issue in pregnancy. So, you know, the placenta is the main is the only source of, you know, nutrition and everything else that the developing fetus is getting. So if there's vasoconstriction, which means the blood vessels spasming and they're having less blood flow in general, either due to vasoconstriction or other things, then it just is not a good thing. Now, opioid use disorder, untreated opioid use disorder can have really devastating consequences for the, baby. And a lot of this is actually not due to the opioids themselves, because the gold standard for a pregnant person who has opioid use disorder is methadone maintenance or methadone treatment for opioid use disorder. And if methadone is not available or due to the patient choice, buprenorphine is a perfectly good alternative. So a lot of these really terrible effects that are linked to pregnancy and opioid use disorder are due to all the other factors like poor nutrition and, a lifestyle, the risk of infections, variety of things. But there is a lot of discussion. It's not 100% answer yet, like what is the accurate thing, like we don't really know, is that the fluctuating levels of opioids in the mother. So let's say you're a pregnant person and you are actively using opioids, whether it is, prescription pain pills, whether it's fentanyl, heroin, whatever it might be, oxycodone, that there will be, through the day, there are all these like spikes of like becoming high and then crashing and withdrawing. And so if the mother's going through it, then the fetus is also going through it, but we don't know 100% if the fetus is going through it, because we don't know how much of this opioids in what quantity will cross the placental barrier and get to the fetus. So, but some amount certainly does. So that's one of the risks. And then there are other indirect risks like exposure to HIV or Hep C, malnutrition. People typically are not following up on prenatal care if they're actively using any kind of drug. And then dangers from drug seeking, like becoming a victim of violence, going to prison. Next slide, please. And these are some of the risks of opioid misuse even during pregnancy. So I would have to say that the first one, neonatal abstinence syndrome, even though it's listed in this, federal government publication as a direct physical risk, because technically it is a direct physical risk, but the gold standard, as I said, for any pregnant person with opioid use disorder is methadone treatment. And so if the mother is on methadone treatment or buprenorphine treatment, then the baby will be born and have withdrawal. They will have neonatal abstinence syndrome, but that is not dangerous for them if it's treated. But it can also result in, untreated opioid use during pregnancy can result in stunted growth, preterm labor that can result in loss of the baby, fetal convulsions, fetal death. It's just a lot of bad things. And these are some of the other really bad outcomes that can happen. These have pretty much stayed stable over many, many years. And they're just a long list: spontaneous abortion, amnionitis, chorioamnionitis. These are like infections of the amniotic, sac, growth retardation inside the uterus, placental insufficiency, which we can also see with nicotine and cocaine, premature labor that then leads to a preterm baby, premature rupture of membranes, eclampsia, which is the hypertension factor, which is extremely dangerous in pregnancy, toxemia, abruptio placentae, which is like a tear of the placenta, which is, again, a medical emergency, and intrauterine death. Okay, so now we're just going to discuss treatment in general. Now, just one thing to remember, that if you are treating a pregnant person with opioid use disorder, they are never to go on naltrexone because withdrawal from opioids during pregnancy can increase the risk of miscarriage. So we don't ever want to put them through withdrawal management, which is the new term for detoxification. And we certainly don't want to put them on naltrexone because this could result in triggering a withdrawal and could result in a loss of the pregnancy. So the gold standard is methadone, as I said, but also buprenorphine is a very good, another option. Typically, I don't like putting these brand names like Suboxone, Subutex on my slides, but the reason I've put them here is because they're very recognizable to a lot of people. So if you have a pregnant patient, you are not going to put them on Suboxone. If they're on Suboxone, you're going to change to the pure buprenorphine formulation. So they should not get the buprenorphine naloxone formulation. The reason naloxone is added to buprenorphine, whether in films or as sublingual tablets in the United States, is because if the patient decides to then dissolve the film in water and inject it, then the naloxone gets activated and will send them into withdrawal. So for a pregnant patient, you don't want to give them the formulation with the naloxone, because if they were to choose to dissolve it in water and inject it, now they would go into withdrawal, which then causes an increased risk for spontaneous miscarriage. So if they're on buprenorphine treatment, we just move them to the pure buprenorphine version. If they decide to inject it, they will at least not have any withdrawal symptoms. And why is methadone treatment the gold standard for patients with opioid use disorder who are pregnant? It helps in multiple ways. It helps to immediately stop this, looking for drugs, finding a way to get drugs, whether it's doctor shopping, whether it's exchanging sex for drugs, whether it's committing crimes, whatever it might be. And it stops the sort of spike and trough of the amounts of opioids in the mother's system. You can refer the person for regular prenatal care. You help them stop using other illicit substances, and including legal or prescribed drugs, lead a more stable life. This might be a moment to say that benzodiazepines are quite dangerous during pregnancy, and a lot of pregnant patients may or may not know that. They improve their nutritional status and also receive some parenting education, some wraparound care. So all of that contributes to better outcomes for the pregnancy and for the baby and for the mother.
Okay, and then I'm going to talk about other substance use treatment for other substances. So starting off with alcohol use disorder. So I have listed here what we would use to treat alcohol use disorder in anyone. So the big three are acamprosate, naltrexone, and then antabuse. And then we also have topiramate and gabapentin, which kind of are used more off-label. This is quite a bit different than opiate use disorder as far as pregnancy, and that none of these are recommended. So there isn't really a gold standard for pharmacologic care for alcohol use disorder. If somebody is in active withdrawal, obviously that needs to be medically managed because that's very dangerous. But as far as an anti-craving medication, there's nothing that's really indicated. And so it would have to be something that would probably be discussed like a risk benefit with the OB-GYN and then in the patient. And but there's nothing that's like technically indicated. Generally, if somebody isn't pregnant, then we usually kind of decide on what based on the patient preference and what their goals are. As far as antabuse goes, that one is makes people very sick when they do drink, and so you have to have a very motivated patient who really understands what that medication is for. Seem to be quite successful in folks who are more binge drinkers and kind of know what their triggers are, so as they go into the weekend, they will take it ahead of time, anticipating and knowing that that's something that's kind of barring them from use. But I've also heard of some patients that will still drink and take antabuse, and they can get very ill doing that. As far as some other treatments to think about, both for patients when they're pregnant, but then also after when they have young children, is to think about parenting classes, and that would be for the mother, but also any other kind of caregivers in the family. And then also domestic violence issues. And that's something that is screened at prenatal visits because it's a very high risk time. But women with substance use are more likely to be victims of domestic violence. And so it's kind of a double whammy there of, they're pregnant, so they're at higher risk, and they have a substance use disorder. So something that, really needs to be screened for, and there are different shelters that they can go to if they are not in a safe place to live. And then any patient who is pregnant should be referred for prenatal care. If there's active substance use, they'll often, if the availability is there, they'll often go to a high-risk OB-GYN because you really want to have the proper monitoring in some of these risk-benefit discussions. And having that adherence to the prenatal care appointments, even if they are actively using substances, can really make a difference. And then it can be very important with these patients to have the right kind of releases so that whoever's doing the prenatal and whoever their OB-GYN is, that they are also part of the discussion as far as their substance use. And then as far as where they're actually getting their treatment, depending on what they are, kind of working with the mother. So there is residential treatment, either short-term or long-term. And there are programs where a mother can go either when they are pregnant or with their young children. And so it's really important to know that those programs exist, because I think that that is a huge barrier to care, because a lot of mothers don't want to have to leave their young kids because that's going to affect their attachment. Again, that idea of I'm a bad mother because I'm having to leave my children. So that really is keeping the family more whole. So that's a really kind of important thing to know. You also have partial hospitalizations or IOPs. And you might have to consider dual diagnosis IOP or PHP if the patient has a comorbid psychiatric condition. And then there's just regular outpatient treatment. Dr. Rao has already touched on this several times, so I'll be pretty brief. For opiate use disorder, the pregnant mother should not be referred for withdrawal management, and instead should be referred for methadone. And if it is withdrawal from alcohol use, they definitely need to be referred for medical care. All right, Dr. Rao, this is you. You are muted.
Sorry. Now we talk about what happens right after delivery. So this is a topic of testing the mother and the baby for presence of drugs at delivery. This is usually outside of the purview of addiction psychiatrists. It's usually the purview of OBGYN doctors and nurses and social workers there in the hospital. So the mother being in a methadone or buprenorphine treatment or substance use disorder treatment by itself is not a reason for anyone to refer to DCF at the time of delivery. If the mom is stable and doing well and they've kind of verified all that, it's not a given. There's some degree of decision making around this. But these mothers often have complex psychosocial issues, and the postpartum period can bring its own complex psychosocial issues and psychiatric issues like risk for postpartum depression or even just baby blues. And so the social worker from the OBGYN department often meets with them to help with referrals and anything else they need. And if they're already in treatment somewhere, they'll connect with them and work with them, which many of you have probably already experienced. If there needs to be a urine toxicology screen, it's usually done within 24 hours. But in Connecticut, for many years, after mother delivers, she has to give permission to give the urine toxicology screen. But you can test the baby's meconium, which is basically the baby's poop, the baby's stool, that the mother does not need permission for. But sometimes the baby does not poop for the first 12 hours, and sometimes later. So until the baby passes stool, this meconium screening can't be done. And the meconium toxicology results sometimes come in 5 to 7 days, by which time the baby has already been sent home with the mom. So that can be kind of a barrier. And that is a sort of decision that the OB team would have to make if they get a pregnant patient who's not in any kind of treatment, refuses the urine toxicology screening. Then what are their next steps? And if they're waiting for the meconium results, toxicology results to come back, but they have to send the mother home, you know, do they make some arrangements? Do they call DCF to say that they're doing this? And an important thing is to discuss all this with the mother in a non-judgmental manner, because the biggest fear that these mothers have is that their child is going to be taken away. And sometimes when they're pregnant, they won't come into treatment because they have other children in the house and they're afraid there's no one to look after them. And they're just afraid that they will lose custody or DCF will get involved. And that fear keeps them from coming into treatment. Also, you cannot really mandate a pregnant person to treatment until they've delivered the baby, because until they've delivered the baby is not a separate, viable human being, even though after a certain number of months in the pregnancy, that's the 8th month or whatever, they're like, at that point, there can be no like medical termination of pregnancy or anything like that. But still, technically, they're still inside the mother, so they're not considered like a separate person. But once they deliver, then it's very different. So this is a little bit about neonatal abstinence syndrome, which is the next issue to discuss in terms of the postpartum period. So if a pregnant patient is on illicit opioids, they never came into treatment, or if they came into treatment and they are on methadone treatment, they're on buprenorphine treatment, the baby's still going to have neonatal abstinence syndrome, which is basically opioid withdrawal in the baby. And it's characterized by signs and symptoms indicating central nervous system, which is brain and spinal cord, hyperirritability, autonomic nervous system, which is just basically blood pressure, pulse, all of that is also like ramping up, GI tract things like, diarrhea, nausea, vomiting, respiratory system dysfunction where they might have trouble breathing. And typically neonatal abstinence syndrome occurs 48 to 72 hours post-birth, but sometimes there's a delayed onset up to 4 weeks post-birth. I don't think that's that common, but I don't know the statistics around that. And untreated neonatal abstinence syndrome can cause significant morbidity like seizures and death of the baby. So this ties into the whole stigma issue and the fear of the mother that they're going to lose the baby because sometimes they may not want to say that they have been using opioids or they have opioid use disorder and the meconium hasn't come back and there's no signs and symptoms and they are not in treatment. They take the baby home, but it can be very risky for the baby. So I think discussing it with the mother is the way to go to try and allay her fears. And sometimes it might involve a report to DCF. And neonatal abstinence syndrome involves extended hospitalization in the NICU, pharmacotherapy, extensive neonatal monitoring. There's no way around that. A lot of times, mothers will suffer from a lot of like guilt and shame, and sometimes they'll tell their partners, they never told me at the methadone treatment program that I'm going to have this, but counselors always educate the moms about this, but it's part of their denial that they feel responsible for this because it can be difficult to see the baby going through all this. But if it's treated in the hospital, it's not something that is going to result in some unsafe outcome for the most part. The first documented history of neonatal abstinence syndrome in Western culture, this was really interesting, appeared in Germany in 1875, and it's documented by these German scientists, Menninger, I'm probably not going to say their name right, Menninger Lurchenthal in 1934. And the first reported cases in the US was in 1892, but I'm sure it's been happening throughout human history. And currently pharmacological treatment, which has been the same for a long time, is oral opioids like morphine or methadone, or less frequently some kind of sedative like phenobarbital, sometimes benzodiazepine like diazepam.
Okay,
So then
and
this
this
brings
is
us to the whole issue of breastfeeding.
oh,
You're
Dr.
going to talk
Rao.
about this,
Yeah,
okay, sorry.
All right. So, and then as far as breastfeeding and folks who are on methadone maintenance, so the amount of methadone in breast milk, it is small. And so it really has to be a risk-benefit discussion, preferably ahead of time when the patient is still pregnant. In a lot of cases, the benefits do outweigh the risk, but really does have to be a case-by-case basis. I think that one thing is that methadone maintenance itself is not a contraindication to breastfeeding. It's more about education. And all women should be counseled, though, on that we don't really know the effects of small amounts of methadone on the developing infant's brain. There really isn't much research on that. So we can't say 100% what the effect will be. Sometimes it can help a little bit with the, again, if they have neonatal withdrawal syndrome, like they're going to be in the hospital getting opiates, but having a little bit of methadone in the breast milk is not going to harm from that perspective. And also, if the mother wants to breastfeed, there are just some general sort of benefits to that for the mother and the fetus as far as attachment, but then also there is a suppression of stress-related neurohormones that are produced with physical stress for the mother, and then there's also a short-term suppression of cortisol, which is in response to mental stress. So I think the overall point of this slide is that methadone is not like an absolute contraindication of breastfeeding, and just needs to be kind of a discussion during the pregnancy with the mother. And then for once the baby is born and it grows up, more into a child, or you run into children who are of mothers who are in substance use treatment. One thing to kind of keep in mind is that if they were exposed to certain substances in utero, there could be certain like developmental impacts from that, and also depending on the environment they're in. So there's a lot of things that can kind of predispose to certain like childhood psychiatric illnesses. So these children might need a referral to a child psychiatrist or a developmental pediatrician, kind of based on what symptoms they're showing. And then it's also important to know what other family members are involved. It might be a good resource if the mother can no longer take care of the parents or take care of the children, but obviously that'd be more of kind of a DCF would be involved in that scenario. And then for these kids, preschool placement can also be very positive because they are having mental stimulation, and that can really help with their brain and social development. All right, and this is you, Dr. Brown.
Thank you. So for any woman with substance use disorder, they are at increased risk for trauma. It's just a reality of the world we live in. It's not their fault in any way. So, if a woman is out in the world, drinking, and it's then there could be predatory people that are, targeting her for sexual assault. They also kind of sometimes get into relationships that may not be the best for them because their judgment is clouded by the fact that they're, in the midst of an active addictive illness. This then can lead to further layers of trauma. There's a lot of research that over the years that has shown that a large percentage of women with substance use disorders suffered from childhood sexual abuse. And that in itself kind of puts you at risk to sometimes tune out certain dangers as an adult in terms of, traumatic relationships. And so then the substance use disorder adds another layer. And I'm sure all of you see this in your day-to-day work, where there's sometimes multi-generational trauma patterns in families, but also multi-generational substance use disorder patterns in families. So some of it is genetic, the substance use disorder, some of it is just the environment in which people grow up in. So, genetic vulnerability is not a given that if you have genetic vulnerability, you're sure to develop something. But in the world we live in, which is absolutely washed with alcohol and drugs, it can be hard to never be exposed to it. So the only place where I saw it skip a generation was actually when I worked in Atlanta for a few years, where I treated people who were from very religious Southern Baptist families, and like the grandfather had an alcohol use disorder, and then the parents never drank, and they constantly went to church and took the kids there. And then the kids grew up and they were like young adults, and now they had some kind of like drug use disorder. And the parents are in my office saying, "How did this happen?" And I'm like, "Look, this is genetic vulnerability. You should have maybe talked to them about the grandfather." Well, try to say it without being blaming. I'm like, look, it's not your fault. It's just genetics and the world we live in. So there are all these multi-generational intertwined patterns that can also contribute to some of the issues that you later see in the children. Like, it's not all like the biological effects of the drugs. We already went over some of this, so we don't have to go over it in details, but some of those issues that we talked about during pregnancy also follow the mother in the postpartum period, where it's a very vulnerable period for any mom, but it's like they could have lack of a stable income. The father of the baby could be uninvolved or underinvolved, or they could be like taking them to court for custody. The dad could be using drugs, or they could be in prison or jail. There could be a lack of emotional support from family or friends who blame the mom for problems. They can be unhoused status, and for the children, they could be frequent changes in neighborhoods, frequent changes in schools. The mom could change, significant others sometimes. So all this results in stressful environment for the mother and the children. And we didn't want to like not discuss psychiatric conditions like postpartum depression and just the postpartum depression, but I think it's not germane to this discussion, except to say that if you are somebody who is treating pregnant patients, then you do have to check in with them postpartum by scheduling an appointment, by having them come in to see you. Are they experiencing any postpartum depression, postpartum anxiety disorder? The most dangerous would be postpartum psychosis.
And I do have slides on this, Dr. Rao.
Okay, so then maybe talk about it. Yeah.
And so we could have a whole discussion on this that's not within the scope of this. But anyone who I think is going to be working with pregnant patients should at least be generally aware of kind of what to look out for. So baby blues or postpartum blues are very, very common. Depending on what you read, up to 85% of postpartum individuals will experience baby blues. And this is probably due to hormonal shifts that occur pretty rapidly in that postpartum period. And it usually begins about 2 to 3 days postpartum, and then should last for less than 2 weeks. And you see mood shifts, crying spells, anxiety, irritability, and sadness. If any of these symptoms are impacting functioning, or if they're lasting for more than 2 weeks, then you want to start thinking about postpartum depression and really be referring that patient for care. This is also something that will be screened at their postnatal visits with the OB-GYN, and a lot of times the pediatricians do it as well, because having untreated postpartum depression affects the mother and the infant really long term, because it impacts that attachment that's forming in the first few weeks to months of pregnancy. And it's something that is it is common. 10 to 15% of postpartum women experience it, but there is just so much shame around it that it can be quite difficult for these individuals to really get treatment. So I think that referral and recommending, if either the patient is saying this or anybody in their life is expressing concern, for them to get evaluation and treatment. They're in the DSM-5, which is, kind of the criteria that psychiatrists use to diagnose. Postpartum depression is not actually in there as postpartum depression. There is a peripartum onset specifier that we use. Again, that's kind of outside of the scope of our discussion, but I think it's important to know that we call it postpartum depression. That doesn't mean it had to start in the postpartum period. This might happen with the hormonal shifts that occur during the 3rd trimester. So the actual criteria for peripartum onset has to be either during pregnancy or within a 4-week period after birth. But I think if at any point you're concerned, this mother has depression, refer them to psychiatry or whatever kind of referral is sort of normal in your system. And as far as peripartum illnesses, there's really a lot of causes of them, and some as far as what is more, if the patient has a past history of any sort of mental illness, they're more likely to develop a postpartum illness. If they have a past history of bipolar disorder, they're more likely, they're more at risk of developing postpartum psychosis. Postpartum psychosis is not very common, but is incredibly dangerous, because that is when you hear about mothers, killing their babies, killing themselves. And so if you have any concerns for postpartum psychosis, absolutely, that's like send them to the emergency department. They should be calling 911 because that really needs immediate treatment. There's also, as far as concern, generally postpartum illnesses, another risk factor is going to be family history of mental illness. And then anything that generally is going to make you more at risk of psychiatric conditions. So as far as the environment they're in, the social support they have, and what kind of coping skills. So all of that, if they are lacking in any of those things, is going to make them more predisposed to have a postpartum illness. So also an area that that can be kind of enriched while the patient is still pregnant to try to make sure they have support once the pregnancy is over. Okay, and then here are the references for our talk. And then any questions, comments, anything like that?
There are some comments in the chat that are really good. Lindsay has written, we see an increase in baby blues and postpartum depression early on as mom watches her baby go through withdrawal and she feels extreme guilt. Sometimes they want to stop their methadone treatment and quote unquote suffer alongside their baby. We have to talk to them that it's a bad idea. Close monitoring is so important to support mom, absolutely. Eat, sleep, and console, where mom is medicine, can be used before any pharmacologic intervention for infants with NAS. It also promotes bonding and decreases length of stay for infants. In addition, because mom is heavily involved in care, it can contribute to her ongoing sobriety. I would just caution around that. So you absolutely need to do eat, sleep, and console, and the mother should definitely be, in a position to bond with the baby, which could include breastfeeding. But we need to remove the stigma. If you had a adult patient who can talk and is going through opioid withdrawal, we wouldn't say, let's just, have you sit with family members and give you weighted blankets, because it's a very unpleasant process, and it can be dangerous for babies because they don't have the same ability to withstand these kinds of autonomic instability. So if the bar should be low to get them started on something in the hospital, but it could be, it should be integrated with these things that you're writing about, absolutely. Then somebody else had asked a question, which is that, are there any studies on the impact of alcohol or opioid use on sperm health? So I personally did not research that when we were preparing these slides, but I would say it's probably much more likely with alcohol. I mean, opioids are not typically toxic to the body in many ways. But I said that the best place is the federal government's big research agencies, NIDA, National Institute of Drug Abuse, and NIAAA, National Institute of Alcohol Abuse and Alcoholism. And you could probably find anything you want there. So I don't want to speak to it because I really don't know the statistics.
And then as far as the question about buprenorphine naloxone combination, so if there is no question that they could be injecting or snorting it, then I believe they could stay on the formulation that has naloxone in it, but I think it would also be, is there some sort of barrier to them getting just the buprenorphine? Because if it is being observed, it would probably be better that they're observed just using the buprenorphine. But I guess it would have to be also about accessibility. If there isn't any subtext where they are, then that would, then that would be a very fair way to do it. And I think it's also just letting the mother know as well that this is a risk if you use it in this way, because most people are aware that, kind of what happens if they do inject it or snort it. And I think just being very honest about that so that we are avoiding that from happening. This
is something that I learned from doing this talk and reading these comments. I did not know that in Canada it's not available as just buprenorphine. It might be available. You would have to ask your local pharmacist, like, because buprenorphine is also a very good pain management medication. So typically the formulations that are marketed by pharmaceutical companies for opioid use disorder contain naloxone, but I'm sure it might be, oh, she's saying she's a pharmacy student. I haven't personally seen it available anywhere. Well, ask your pharmacy preceptor. Maybe it's available in some way, but maybe Canada has just decided no buprenorphine without naloxone.
I would also wonder about things like Sublocade or sub-Q buprenorphine could be an option.
Yes, it's definitely a thought, but not if they've never been on it before, right? So Lindsay's also writing another risk factor. I can't recall if you mentioned it for expectant mothers with opioid use disorders is risk of overdose. Absolutely, we didn't mention it. In Arizona, the opioid epidemic is at an all-time high, where most of the opioids are illegally manufactured, counterfeit pills, and extremely deadly. Yeah, so there was a big NPR news story just yesterday, I think, or day before, that now, I mean, we already are in the midst of an opioid epidemic, but now, most recently, the United States is experiencing an unprecedented amount of opioid, illicit opioids being brought into the country, predominantly from China and Mexico. And a lot of this is made to look like pain pills that you would get at your pharmacy. So people are dying in New England and all over the country, but the biggest places where these drugs are flooding the market are Arizona, and I think they said Texas, but Arizona was definitely one of those two states. So another person has asked a really sensible question. Hunter is asking, as I understood, naloxone was the risk, and so pregnant women were transitioned to Subutex because buprenorphine itself is the blocker and not naloxone. The actual function is the same. So this is a little bit of a complicated pharmacology answer, but it's not that complicated. So because buprenorphine is a partial agonist, it will bind very tightly to the mu opioid receptor. There are many opioid receptors. The mu opioid receptor is the main one that's mediates like euphoria and also the physical dependence, but also like just this, opioid use disorder itself. And so it'll bind very tightly and it will kick off any kind of full opioid agonist. So if the patient, so we have to educate our patients when they start on buprenorphine that if you're not already in full-fledged withdrawal, then when you start the buprenorphine, there is a risk of withdrawal. It's a very good point that Hunter brings up, because if you're taking a pregnant patient who is using agonists every day, which is what people are using, they're not using partial agonists, it's rare, then the buprenorphine itself could be a risk for withdrawal management. So there are some complicated induction protocols that people sometimes do where they will like put them on buprenorphine, but then sort of cross taper.
I also think there's kind of two scenarios we're talking about here. So just to clarify, you have the patient who is stable on a buprenorphine and naloxone combination. And in that patient, you're just going to remove the naloxone if that's possible for you.
Exactly.
If you come and there's a patient who is using, fentanyl or any sort of full agonist opiate and they want to get treatment, then the gold standard is methadone, and you would just move them to methadone, because if you were to switch them to Suboxone, that would precipitate withdrawal in the way that Dr. Rao is talking. So really two different patient populations here, and you need to kind of think about which one you're treating.
And have an honest discussion with them, Somebody else has written, Michigan has a peer navigator program where a peer recovery coach works with the mother with substance misuse problems during pregnancy and 12 weeks after. That's great. That's Carol has written that to everybody. And then another person, I just see their Samsung number. Thank you. Very informative webinar. Question, please. What's the best way to treat alcohol during pregnancy? Is it chlorodized epoxide, or rather is diazepam a safer option? Both are safe options because they are both long-acting. So you could do diazepam or you could do chlorodized epoxide. Sometimes in patients where if we don't have liver function tests back, we will use lorazepam, oxazepam, or temazepam because they only go through the liver once and not twice. But if we have the liver function tests back and the liver function tests look reasonable, then we can use any of these other benzodiazepines.
Yeah,
What an engaged audience.
And I think a lot of the patients who are pregnant going through alcohol withdrawal, a lot of these are going to end up being in some sort of medically supervised. I would not do it outpatient. I think that you would want to do it in a medically supervised scenario in which you had like OB-GYNs there as well, because they might have a different answer than us about what their thoughts are. And so I think it would be, and I know a lot of it's also institutional. You know, at UConn, we use a lot of lorazepam, but then at other places, you know, they'll use a lot more diazepam, or, you know, it's really I don't think though that one of them is a different, I'd have to look. I think they're the same pregnancy category, but don't quote me on that.
There was one other thing that came up in the chat. But now I can't remember where it is. Oh, somebody asked if we could get the slides. We will definitely send you the slides. But as we are presenting, I noticed that we have to make some tweaks in our language. So and maybe update one reference. Although we went through everything with a fine-tooth comb before we prepared the slides, but we've missed one or two things. So we're just going to make these small edits and try to send them in by the end of next week or the week after, and then they can be distributed to anyone who wants them.
Yeah, I'll send them to Heather, and then from there can send them to, you know, everyone who came. And
yes,
you know.
Absolutely.
Thank you everyone for being such an amazing audience. It's so many positive messages in the text and questions. So we're at 107, so we're going to stop unless somebody has anything else to ask us.